Hi, good morning. Thank you everyone for logging in. I am super excited to be doing this live session to discuss um, endometriosis, one of the most common conditions that we see when people are trying to get pregnant. My co-host.
Hey, Dr. Levine.
Hey, good morning. Thanks for logging in and thanks for making time to do this today. I'm so excited.
Yeah, likewise. I have a couple of questions that came in from my followers. I'm excited to share those with you and get your insight and get your answers to those questions. So yeah, this is great. I think you're a fantastic resource for the endo community. So it'll be great to chat today.
Thank you so much. So why don't we start with some introductions? Why don't you tell everyone about who you are, about your Instagram, about what you're doing, and then I'll tell people about me and us and what we do.
Sure, yeah, sure. So I'm Cindy and I'm a registered dietitian. I'm an endo warrior myself as well as an infertility warrior, so I'm the full package. And with my Instagram page, endo.fertility.dietitian, I'm basically sharing evidence-based information around diet and lifestyle interventions to support people with endometriosis as well as fertility.
Wonderful. So my name is Dr. Brian Levine. I am a double board certified reproductive endocrinology and infertility specialist. I have the pleasure of being the practice director of CCRM New York, which is a fertility clinic in Midtown Manhattan. We've been around now for 5+ years, and we've had a lot of great success. We're part of a network of clinics, so we have 11 clinics around the country in North America. So we're pretty much in almost every big city that you can imagine. But one of the reasons I'm so excited to be talking today is March is Endometriosis Awareness Month, which is huge because finally we're seeing that endometriosis is getting the attention that it really needs and deserves. And second
Mhm.
is that endometriosis is something that so many patients come to us with, right? It's a diagnosis of questions. They come to us with uncertain etiologies of infertility. They've been battling unexplained infertility for a number of years. But they know their body, right? They know that something feels off. They start to feel burning. They start to feel full. They start to feel bloated. And they've gone to a number of different places. They've done IVF, they've done IUI, they've done interventions, and nothing's working, nothing's sticking. And so I'm really glad that you and I can talk today because endometriosis is really in the forefront of our diagnostic panels. We help patients understand their fertility. We help them understand if there's someone who may be battling with endometriosis. And most importantly, is that we acknowledge that endometriosis is the third most common reason that we see patients go through IVF. The most common
Mhm.
reason being number one, age associated infertility, right? Americans in general are just waiting longer to have children. So there's chromosomal abnormalities. Number two, which is right behind age, is male factor.
Mhm.
Right? Women don't need to hang themselves on the cross. It is completely equal male and female in the etiologies, the reason people deal with infertility. And number three is our story today, right? We're going to be talking about endometriosis, this really inflammatory condition that really sets people up to, unfortunately, not achieve their goals when going through infertility evaluations and treatments. So we're going to talk about how to treat it. We're going to talk about how you and I both address it. And most importantly is we're going to answer your questions. So keep those questions coming. Send us them in the comments or you can message them. And let's go from there. So I guess my first question for you is, tell me your story. How did you actually come up with the diagnosis of endometriosis and who was the person who helped you understand what that diagnosis means?
Yeah, so it took me, I'm one of those typical stories you hear, unfortunately. It took me very long time to get diagnosed. So it took me 15 years. For my very first period ever at 12 years of age, I had very painful periods, like to the point where I was losing total loss of control over my body, vomiting, loose stools, fainting, you name it. It was happening, and the pain was just insane.
Could you just say
Excuse
that one more time for
me.
everyone again? It took you 15 years for the diagnosis to be made.
Yeah, 15 years to get a formal diagnosis. So I did have
Wow.
a laparoscopy in 2018. So it hasn't even been that long since I've been formally diagnosed. Excuse me, I don't know what's going on with my voice. So yeah, 15 years. And I'm one of those people, and I know this varies a lot too based on the surgeon, right? And I don't know if that's something you can speak to maybe later in our chat, but uh, I didn't see a lot of improvements in my symptoms following excision surgery. The one thing I have to say I did see improvements in was pain with intercourse improved, because I did have a big nodule on my cervix, which was removed. So can't complain about that. But otherwise, the main supports really that have helped me are diet and lifestyle, and really just addressing, those three pillars that I base my practice on, right? Immunity, so gut health, hormone balance, and just targeting that inflammation. So that's really my story. Yeah.
So my mother-in-law is walking behind me, and
Oh,
okay, you can stand up and go. We have a new baby at home right now.
oh,
So
congratulations.
we're doing, socially distanced, single visitors only. So I apologize in the
No,
background if
that's
you hear
okay.
crying. So, endometriosis is one of these conditions where there's actually a Nobel Prize just waiting to be taken. Um,
Mhm.
and most people don't realize that, right? Like, you can't figure out what the next Nobel Prize is going to be. My guess is that the next Nobel Prize will probably be for the people who created the vaccine for COVID. But in the future, they say there's two Nobel Prizes just sitting for the taking in women's healthcare. And the first
Mhm.
one's for endometriosis, and the second one's for preeclampsia, which is
Oh, yeah.
unfortunately a common cause of maternal mortality and morbidity.
Mhm.
Um,
Mhm.
but endometriosis is still unknown of how it happens. But here's the story that most people hear, which is that at some point when your mother was pregnant with you, there was an accident that occurred around 6 or 7 weeks of embryological age, where some of these cells that should have been contained within your uterus ended up outside. And for whatever reason, those cells just kind of floated around and just hung out there. And those cells need estrogen. So it wasn't until you started getting your period when you were 12 or 13 or 14 years old that those cells were actually activated by you making an egg and the estrogen that was there. So that one theory is called the migration hypothesis. And this one has been proven in many different scientific studies. However, there's no animal model, right? There's no real like laboratory rat that you can induce endometriosis in by moving those cells from one to another. The second theory that's thrown out there is called the regurgitation theory. Literally, your uterus threw up in the wrong direction, which means that when you first got your period, instead of those cells coming out down your uterine cavity, down your cervix, out your vagina, and out onto a pad or a tampon, instead, those cells were regurgitated backwards. They went through your fallopian tubes and they went backwards into your abdominal cavity. Well, some of those stem cells that were released at that time ended up implanting all over your body. Regardless of the cause, was it this embryological accident that happened before you were ever born, or something that happened around the time of puberty? What we do know is that those cells, those endometriosis cells, are the same cells that we see normally in your cavity. They respond to estrogen. For the first 12 days of your cycle, just like your lining is growing, those cells are growing. And when you're about to get your period, which is a result of that progesterone dropping in those last 10 days of your cycle, those cells are also being affected. That's why people have pain, cyclical pain, around the time of their period. Now, what happens is that those cells can implant all over your pelvis. And so when those cells implant, it's kind of like, think of it almost like a shotgun went off. One of the ways that we describe it is this word called miliary, where it's kind of like spread everywhere. And if you've ever heard an endometriosis surgeon say that their surgeries are just as difficult as a cancer surgery, well, they are correct. Because those surgeries can be incredibly intense, because those cells can be implanted on the bladder, on the lower part of the inside of the vagina, on the peritoneal body or the walls of the internal organs, and on your bowel. I cannot tell you how often I see a young woman tell me that she has, like the average like young woman sick stomach. Like she's any other 20-year-old girl and her stomach just hurts and she's on all these medications. And she had a
Mhm.
colonoscopy and it was normal. Well, if she actually just had a laparoscopy, someone would have seen on the inside that endometriosis was sitting on top of her bowel. Unfortunately, there was a study that was done called a meta-analysis, which is where we take a bunch of studies and we put them all together. And in this meta-analysis, we were able to see that it requires 40 laparoscopies, 40, to identify one case of endometriosis in the infertile patient. So unfortunately, the pendulum has swung from in the 80s and 90s that everyone had a laparoscopy for their evaluation of infertility to now pretty much nobody gets that laparoscopy. So in fact, although science has advanced and technology has advanced to the point that laparoscopies aren't routine, the diagnosis of endometriosis is often missed. And I think your story is really, really common.
Yeah, absolutely. Absolutely.
Could
That
you
was a really nice overview.
Well, thank you. Could you tell me a little bit about your practice of how diet influences endometriosis, right? We know that these cells are all over your body. We know that these cells are all over your bowel. We know that they're pretty much everywhere in your pelvis. Help me understand what you recommend to people for their diet to address this.
Yeah, so my practice, it's based on three main pillars, right? So we know that there's this immune system dysfunction piece in endometriosis, that the immune system is not quite responding to these adhesions as it normally would to other similar, I guess, tissues, you can say. So we've got that immune system dysfunction piece, and we know that the large majority of our immune system is located in the gut. So the better your gut health here, the more often you're having a nice regular bowel movement, nice healthy flora, the better that's going to translate in terms of immunity, right? You're going to have a stronger immunity. You're going to be able to support your body and your immune system in better targeting those adhesions and actually responding appropriately, right? Like if you're getting to a point in your cycle where your body is burning up and you're losing control, like it's coming out both ends, and you're on the verge of, you're questioning whether should I call 911 or should I hit up the ER, right? Because it's just so unpredictable and you just don't know, right? So that's all related to immunity, right? We really want to be able to calm that so we're not getting that crazy reaction. So naturally, food has everything to do with the state of the gut, right? If we're eating a lot of white refined processed foods, drinking a lot of sugar sweetened beverages, not having, regular structured meals, no more than 4 to 6 hours apart with, whole grains, quality proteins, and lots of fiber coming from our colorful fruits and vegetables, well, then you're not stimulating the migrating motor complex. And then we're also dealing with this inflammation that inevitably is impacting digestion also. And we know that inflammation impacts digestion in so many ways, whether it's, reducing stomach acid or slowing motility, or contributing to loose stools, for example. So that's one piece. Then we've got hormones, right? Like you nicely spoke to, right, around these tissues responding to estradiol. So, there's a ton we know about nutrition and how it can support hormonal balance. Blood sugar control, super key there. So that's a point going back to regular structured meals. We know phytoestrogens are really helpful. There's a lot of literature now supporting, whole food sources of phytoestrogens being really supportive for hormone balance. And then we know that there's a ton of food that, can do quite the opposite, which is encourage a hormonal imbalance, like, excessive alcohol intake, excessive, white refined carbohydrate intake, even large amounts of animal proteins too, right? And then there's inflammation. So if we're eating an inflammatory diet, right, one that's got a higher omega-6 ratio to omega-3, we now know that the ratio of those fats in the North American population is about 25-1. So that is massive in terms of increasing inflammation in the body. So really just, improving that, lots of phytonutrients coming from our plant foods, our fruits and vegetables. That's going to be really key for reducing inflammation. Addressing food sensitivities, because that's a source of inflammation as well. Addressing, inflammation coming from our beauty products, right? Because a lot of these beauty products these days now contain endocrine disrupting chemicals. So taking a look at those, making sure we're not putting anything in our bodies or on our skin that could impact. Like I have to say, I when I was really addressing, fertility for my husband and I and my endometriosis, I did revamp all of my beauty products. products. You know, we use just pure soap, one ingredient. I have a lot of like beauty counter products, which are nice and clean. And I have to say, you know, we got a Berkey for water filtration, and I have to say that it's made a massive difference. And you would never think
100%.
these things would make a difference, but they do.
So I want to bring up two things you just mentioned. The first is the anti-inflammatory diet. So this freaks out every husband that I talk to. Because, and by the way, I have to tell you, I'm so thrilled as I'm looking about who's in our Instagram live right now, because I'm seeing a number of my patients that are in there. So thank you guys for logging in. And I apologize in advance because you've all heard this before. But, you know, I tell all my patients that you need to avoid the 4 W's, right? So that's the white sugar, the white rice, the white wheat, and the skim dairy products. And if you can eat full fat dairy, if you need to eat dairy in general, I think you could just avoid dairy because it's weird, right? Like we really are the only animal that eats the milk or drinks the milk of another animal. But if you are going to have dairy, at least use full fat, because skim dairy products have a lot of sugar in them, which people don't realize that when you remove the fat, you leave the lactose still present. But in general, if you're going to try to do the anti-inflammatory diet, it is impossible to be on an anti-inflammatory diet if your partner is still ordering pizza at home. It is impossible. It is not fair. It is cruel and unusual punishment. And so what I always say is that the same way it takes 2 to tango, if you're going to go into the anti-inflammatory diet, so should your partner. And the reason is that you need to really be on it 100%. You can't be on it halfway. And if you talk to enough patients who've suffered with endometriosis, they tell you that it takes about 15 to 30 days of being on the diet to start to feel anything. And then when they cheat is when they notice it. And that to me is the most interesting part. Patients will tell you, I felt amazing. And then I got my negative pregnancy test and I went out and I had rigatoni bolognese with a ton of Parmesan cheese on top, and I had cheesecake for dessert, and I felt terrible. And what I find is that that's because that fire, you may have quelled it with your anti-inflammatory diet, but it is ready to rage again. And so you really need to, live on the straight and narrow. Now, here's something really cool. There has been a lot of studies done, because I'm sure you know that nearly 43% of all the deliveries in America are ending up in cesarean sections, especially at the major academic medical centers. Which, by the way, I do think cesarean sections are a good thing for the right patient population, because that limits, again, risks to baby and mom. But what they're finding is that at the time of cesarean section, in patients who have had a history of endometriosis, they see very little disease. So if all of a sudden you and I are talking about this thing being estrogen receptive, and then you have a C-section and you're not seeing estrogen receptive growth, right? Like pregnancy is an entire, 9.5 months of estrogen. Why doesn't endometriosis grow? Well, the answer is to your exact topic before. It's an immune response. There's something about pregnancy that's protective about the immune system, allowing endo to grow. So if you can get on your anti-inflammatory diet pre-pregnancy, you could set yourself up for a successful pregnancy straight through. The converse is that if you have a raging endometriosis going on, and then you're lucky enough to get pregnant, God forbid, you can also have the converse happen, which is associations with early miscarriages, implantation failures, biochemical pregnancies, things like that. You're hitting the 3 main points that I think everyone needs to take away, which is that it's inflammatory, it's immune, and it's hormone. And, you brought up the makeup. And I tell everyone, makeup is just one, but don't forget all the plastics that you're putting all your foods in. And if you're microwaving your foods in plastics, you're basically impregnating your food with potentially these estrogen modulating substances. And by the way, estrogen modulators are great. Clomid, the oldest, safest fertility drug known to man. Letrozole, one of the better drugs that we use now for patients that helps keep your estrogen low. Those 2 medications are estrogen modulators. But we don't need to modulate our estrogens with what we're putting in our mouths.
Sure. Yeah. And those ones will likely modulate it in the direction that we don't quite want it to be modulated in,
Yeah,
if I can say that. I just want to make one comment. I just really want to be mindful of the language because, people with endo are people too, right? And we like pizza and we like things that maybe aren't identified as, the healthiest whole
sure.
food. And, people with endometriosis too, the prevalence of disordered eating in this population is insane, right? And I'm sure you can imagine it is insane because you hop on Google and you say, and you write in endometriosis diet, and it tells you all the things you're not allowed to eat, right? And I can tell you from my experience, I spent 2 weeks cutting out, like before I was informed, before I was a dietitian, I took 2 weeks and cut out everything that Dr. Google told me to cut out, right? And I was miserable.
Right.
I was miserable. It was the worst. I was malnourished. It took me 6 times as long to prepare a meal because I had to include all these fancy ingredients. And so that's why my practice, although I focus on, targeting inflammation, and sometimes the source of inflammation is food, like that's a fact, right? We have to acknowledge that, whether it's gluten, whether it's dairy, whether it's, alcohol or sulfites for people. But I practice with the idea in mind that we don't necessarily have to restrict. If we've identified that in you specifically, gluten is a trigger, let's modify that intake. Let's get creative. Let's change the mindset around that. Let's say instead of I can't eat gluten, I'm going to pick not to eat gluten because I know it's going to be better for my body.
Brilliant.
But I do not support completely going down the elimination diet route. If you're not somebody who absolutely has to do that, you're human. You are very much allowed to enjoy foods that other people are enjoying without the consequences. So for me, it's just a matter of really focusing on, optimizing that immunity, optimizing the hormones, and then reducing the inflammation in whatever way we can, right?
I think and I think you bring up a really valid point, which is, right, we know that 1 in 8 couples are going to battle with infertility worldwide.
Yeah.
So you're dealing with a devastating diagnosis. You're not achieving something that was supposed to be so private and so natural that now you're going to seek help. The last thing we have to do is take away one of the greatest pleasures, which is eating.
Yeah.
And I think you bring up such a great point. For the Endo Foundation, for example, on their website, they have lots of great recipes. So how can you replace, simple glutinous substances with maybe whole wheat or rolled oats, things like that. Or to the men who are watching this right now, embrace the diet that your wife is on. Do it as a team. I think the greatest thing about the pandemic was that many people didn't want to leave their homes. And so they started cooking together and doing meal planning and doing planning of meals together that you can put on the Mediterranean diet, right? That's a very easy diet to follow, and it's delicious. And so, going back to, natural foods and figuring out food shopping lists and things like that. What I will say that you also brought up that's so important is the psychology of this diagnosis. Endometriosis for many feels like a terminal disease. And the reason is that it feels like pregnancy is not happening and something has been taken away from you. So it's a real devastating diagnosis. What you should know is that there are people like myself and yourself who dedicated their lives to educating and treating. And if people with endometriosis weren't getting pregnant and staying pregnant, then we wouldn't have so many people out telling their stories. Right? So you can get past this. Absolutely get past this. It's
we got somebody
that's
who
my
wants to join
mother-in-law
it.
going back again.
That's funny.
So in our last few minutes, let's address some of the questions that people have had.
Okay, so I've got a couple for you. So I hope we have a few more than a couple minutes. So, okay, so one of the first ones that came through was around egg freezing. So maybe just some thoughts around egg freezing, who should maybe consider egg freezing in the endometriosis population? What kind of things are we looking for when somebody's deciding egg freezing? If you could just speak to that a little bit. Yeah,
so egg freezing has become incredibly common in the last few years. It's only been legal in the United States since 2012. Prior to 2012, it was deemed an experimental technology, and many people don't recognize that. With that said, Egg freezing is the first step of IVF, so it requires 10 to 12 days of taking shots or medications. And the people who should do that are those who want to protect or preserve their fertility. The jury's still out about the ideal age to do this. In my practice, with my laboratory outcomes, I tend to recommend that people do this somewhere between ages of 32 and 35, because we know statistically that they'll be able to get pregnant on their own, hopefully for the first child. That they may reach some difficulties. I also recommend that patients do egg freezing prior to doing any endometriosis surgery where they have a lesion in the ovary. And the reason is that if you're going to have a lesion in the ovary or a cyst removed, it's quite possible that they're going to need to do cautery to stop any bleeding during the surgery. And the cautery can be destructive to the potential eggs in that ovary. So if you're going to have a major surgery, protect and preserve your fertility ahead of time.
So for somebody who's, let's say, younger than that age group that you suggested, the 32 to 35, maybe fertility isn't even on their mind, but do have ovarian cysts, then that would be a recommendation?
I would.
Okay, wonderful, good. Okay, next question for my audience was, recommended protocols for FET that can increase success with endo. I don't know if you can speak to that.
Yeah, so FET is short for frozen embryo transfer. Most clinics have 4 different styles of transfer modalities or protocols or cocktails of medications that they use. At CCRM, I think what we're really known for is paying attention to this embryo transfer. And because so many of our embryo transfers are frozen, we just have a lot of experience with them. And in fact, we have 3 different protocols alone just for endo. And so we call them our mild, our moderate, and our severe protocols for endo. And they all are related to keeping your estrogen low. So the concept is that we don't want you to be inflamed at the time that we're putting back this precious embryo. So it might be using a medication called letrozole to keep your estrogen low. We might have pre-treated you for a month with something like birth control pills or a medication called Orilissa, the first oral medication that's been approved by the FDA for the treatment of endometriosis. Or we might even use a medication called Lupron. And Lupron is the oldest drug that we know of for treating endo, which actually puts people in a synthetic menopause. And sometimes we put people in a 1 or 2 or even 3-month menopause prior to an embryo transfer so that we know that their bodies are completely suppressed prior to now putting in this precious embryo that people worked so hard to create.
Okay, so this is just a kind of a follow-up to that because I'm genuinely very curious about this and I get a lot of questions about it, and I'm not the right professional to ask about this, but are there any concerns around doing like a suppression, like one of these sort of suppressive, I call them methods, right? Because you're suppressing the estrogen, non-natural estrogen. Is there any concerns around that? And then, maybe successfully achieving conception or pregnancy or implantation rather, and then, your body having to basically ramp up and start producing its own estrogen and getting those hormones, right? Is my question clear?
Yeah, so many people say, oh God, you're going to put me in menopause. I'm going to get stuck there.
Yeah.
So the answer is the medication only lasts for a certain amount of time. It is designed to have a 30-day length of time. There is a 3-month formulation, and it is reversible. So yes, it sounds scary at first, but it works really well. But the most important thing to recognize is that any treatment that you're going to do is about a partnership with your physician. And I truly and honestly believe this, in that you should partner with your doctor and have an open and honest conversation. And your doctor should feel very comfortable in telling you the risks, the benefits, and the alternatives. If they tell you it's their way or the highway, that's not a good doctor for you. You don't have a good relationship. So you should be able to sit down with your doctor and say, these are my concerns. How do we address them? And that's why for many patients now, we're using this medication Orilissa much more often. It's reversible. It only lasts as long as you take the pill. And so for many people who have struggled so long with infertility, putting them in a medical menopause is very scary to them. So instead we use this medication Orilissa with the same great effects.
Okay, so this is kind of a general question, but do you have any special tips specifically trying to conceive tips, keeping endo in mind. So anything specific to endo that you maybe haven't touched on
Yes.
already?
So I think the first thing is to go back and use the most important fertility app that you have on your phone, your calendar, right? You don't need to go download something with a single syllable like Glow, Flow, Clue, Blue, any of those things, right? Like use your straight up calendar app and know your cycle. Do you
Yeah.
have pain when you ovulate in the middle of the month? That's called Mittelschmerz. Do you have pain when you get your period? Do you have pain with intercourse? Do you require Advil or Tylenol or Motrin or Aleve? How many are you taking? Think back to high school. Did you ever skip days when you got your period? Think back to college. Were you unable to go to class when you got your period? Think back to knowing your cycle, because that can tell the doctor or your treatment team. And I always say it's not just me, right? There's a team behind me that we all are working together to help the patients achieve their goals. But that can help the team understand who you are and what you need. So my number one tip for anyone trying to conceive is know who you are. The second thing to know is that plumbing is the most important part of this whole process. And by plumbing, I mean, A, does he have sperm? And B, do you have 2 open fallopian tubes? If you have chronic, unremitting pelvic pain, there's a high likelihood that you can have blocked fallopian tubes. It doesn't mean that you had a history of chlamydia in the past. It doesn't mean that you have, cancer growing in your body that's pinching your fallopian tubes off. It means that this really invasive disease, endometriosis, could have actually scarred your fallopian tubes and kinked them, and that instead of sperm being able to get inside the uterus and get to the fallopian tubes, they're knocking on a locked door. It's really important for this to happen. It's also important, though, for your doctor to know about your potential risk of endometriosis if they send you for the test to check your fallopian tubes, because they need to treat you with antibiotics so that you don't end up with an infection afterwards. But again, know your cycle. If there's anything that I can ever tell people to take away from anything that we talk about, just know your cycle, because you can offer so much information. And during this pandemic, doing all this telehealth, what we have learned is that the patients are the best historians. I don't need a fancy ultrasound or blood test to really, know exactly what's going on. I can get a good idea by talking to someone. If they tell you that they're trying to conceive, but they're having sex only, one time when they ovulate because it's so painful, that's a pretty strong history suggestive of endometriosis. If someone tells you that when they were, in their 20s, they ended up in the ER because they had a ruptured cyst, that's a pretty good history, again, of endometriosis. If they tell you that they once had their appendix removed and the doctor saw these chocolate things everywhere, that is suggestive of endometriosis.
Yeah, wonderful. That's great. So I think a lot of people underestimate just how much information just listening to our bodies can give us, right?
Please, yes.
So that's a wonderful, wonderful answer to that question. So I'm hoping that the answer to this question will provide a little bit of hope to people in the endometriosis community. So we know, and you really beautifully explained this in the beginning, endo is in top 3 in terms of causing fertility concerns. We know that 30 to 50% of people with endo will struggle to conceive, and then we know that 50% of cases of infertility are related to endometriosis. So how do those stats change when we utilize some of these assisted reproductive technologies?
So if you have a doctor that's picked up on this, and again, I'm putting the stress and the strain on the doctor, right? The patients are not responsible for coming in with their diagnosis. The patients are just responsible for showing up. It is my job. It is our team together that make this diagnosis. But I would say that when the diagnosis is made, people should know that we can take them back to baseline. And by baseline, that means take you back to your age-associated risk factors. Unfortunately, many people spend many years trying with no diagnosis. So they cross age groups. And this is really important to recognize, is that you might go from 28 to 35 trying for those 7 years and never achieving your pregnancy. And when you finally see the fertility doctor and you're 35 years old, you should know that you're going to have the risk factors of a 35-year-old, not that of a 28-year-old. But it's not 35-year-old and takes them off the top. When diagnosed appropriately and treated adequately, you should know that you do have a good chance of helping to achieve your goals.
Wonderful. That's great. So lots of hope for our community, right?
Yes,
We have such,
absolutely.
the technology now is so advanced. We have wonderful doctors like yourself who are
Well,
really
thank you.
patient-centered. So as long as it's incredible how much of a difference a really good, knowledgeable patient-centered doctor, how much hope and how much change and how much success we can really have. So that's great. So I guess my last question for you, 'cause I think we're running out of time, is, what advice would you give to somebody who's beginning their fertility journey, and maybe also for somebody who's, maybe closer to the end? I listened to the video on your website yesterday, and I really enjoyed your story about, the patient that had come back and had been through several IVF protocols and, was basically at her wit's end. She just kind of gave up, and you were still able to help her conceive. And now you go to her child's birthday parties every year.
Every September. Yeah.
So what kind of, I guess, a little bit of advice for the people beginning their journey, and maybe a couple words of wisdom or support for that person who feels like they're at the end of their journey
So I'll give
with
you the same
fertility.
advice for the person at the beginning and the end,
Okay.
which is you're not alone. And you do need to be your own advocate. You do need to openly address the elephant in the room, which is that you need help. But you should know the responsibility for making the plan is not yours. There are a lot of really great doctors out there. The infertility community is really small, both for patients and for doctors. There's lots of resources, online resources like this today, your practice, my practice, lots of great Instagram and Facebook and TikTok and social media resources. But just remember also that as you look on social media, people only post their best lives, right? People actually pick their best photo to post. They don't ever pick the one of what it looks like to have an infected scar after you've had endometriosis surgery. They don't show you what it looks like to wake up with your stomach just being black and blue. And you should know that you're not alone. You should know that you just need to really get hooked up with a treatment team. And it's not me. It's not just one doctor, one nurse, one dietitian. It's a team. But you should know also that endometriosis doesn't mean that you're at the end of your rope. It just means that you're on a journey that other people have successfully achieved. And you'll get there. And so it's going to be about your emotional fortitude and about your doctor. And don't be afraid to ask your doctor why. You're not a lab rat. You don't have to let your doctor just prescribe and you just inject. Ask your doctor why. Ask your doctor how. Partner. I give every patient my email address. I don't block my cell phone number when I call people. People are actually relatively respectful of that. And the reason is that the best questions happen when someone has the chance to process. This is a rough journey. So, you should know, but you're not going on this path alone.
Wonderful. That's a very hope-filled message. There was a couple of questions, Dr. Levine. I don't know if you have more time. There's a couple questions that came through the chat. So
Let's see here.
one said, I suspect I have endometriosis. What should my next steps be? And what should my key points, what should my key points be to my doctor? Or what should you talk? I'm assuming you're asking, what should you talk to your doctor about?
So I think that when the diagnosis is made, you should ask, what is the short-term and what is the long-term goal? And that's a really good conversation to have. What are we looking to do over the next 30 days? What are we looking to do over the next 90 days? Right? Are we looking to get eggs first or get embryos or, treat the disease? Are we looking to get an embryo put back inside of you? Or are we looking to get surgery to remove all evidence of disease? So I think that's what you should do is when the diagnosis is made, talk to your doctor about what is the short-term, long-term plan.
Yeah. And I think if you have suspected endo, depending on what your symptoms are, and much to Dr. Levine's point, what your objectives are, like, are you looking to reduce pain or improve fertility? The first step may actually be getting a referral to an experienced excision specialist so you can actually get that diagnosis. So there was a question also, Dr. Levine, about the link to this live. Are you going to be sharing it on your Instagram?
Absolutely. So we're going to share it in 3 places. I'm going to share it, you're going to share it, and we're going to share it with the CCRM Instagram as well.
Wonderful. So you can find it in all of those three places. Okay, another question came in. Gluten, dairy-free foods are usually overprocessed. Any thoughts on that?
Yeah.
Okay,
So I'll tell you mine and then you can say yours. I always tell
sure.
people, eat food, don't eat products.
Yeah, that's a
Right?
good
If you
point.
can't pronounce the ingredients, you probably should not be putting it in your mouth.
Yeah, totally agree with that. So there is a study done in people with endometriosis around gluten. 75% did see improvements in symptoms with removal of gluten. So it's really the one food that we have solid evidence about that, you know, may actually be worthwhile removing for people with endometriosis. It does seem to be quite inflammatory. However, I always tell people, like, if you're somebody who absolutely loves gluten and you know you can't get by without it, then I would definitely start with removal of the processed forms of gluten, right?
Right.
Like Dr. Levine mentioned, the white refined stuff, picking the whole wheat as often as possible, picking the whole grain versions of gluten containing foods like spelt and barley. These are very nutritious foods, but still naturally contain gluten. And sprouted grain breads are also great. Dairy, there's a lot of evidence that dairy, full fat dairy, actually is very protective for fertility. And we know that fermented dairy products are also very helpful because they do contain probiotics and vitamin D being a very anti inflammatory nutrient, probiotics being very helpful for supporting gut health and immunity. So, fermented dairy. And then sheep and goat sources tend to be a bit better tolerated in my experience in people with endo, but this is definitely a preference and an individual choice. So you kind of have to either figure it out for yourself or work with a dietitian like myself to figure out, you know, whether dairy is actually something that's triggering your symptoms. But certainly, I mean, there are lots of foods that fit into that category that are processed, like ice creams and frozen yogurts and things like that. But there are also lots of whole food sources of dairy, which are wonderful for our health. I joined late, so I'm sorry this has if it's already been covered, but any input on an IUD's effect on fertility and endo in the long term?
So IUDs are a wonderful way to help control endo because they can actually help keep your lining of your uterus thin. But if you have deep pelvic implants, you may still have ovulation, even though you're not having bleeding, and you still may have pain. So I would say is make sure that you're making that decision for an IUD to be placed. I assume this is about a hormonal IUD, that you're having this conversation with your doctor, and that you have a plan of how this is to treat your symptoms. Many people use IUDs in concert with some oral medications as well. But again, I would have this conversation with your doctor about this.
Yeah, that's not in my scope, so I'm not going to comment on that question. But I do have a follow-up question about this, Dr. Levine, because I have actually a couple of clients, patients who, after having their IUDs removed, saw a decrease in pressure in the abdomen and pain. Can you speak to that at all? Is it related to those deep implants like you just mentioned?
Yeah, so I think sometimes people find that they also have an associated condition called adenomyosis, ADENOMYOSIS. This is kind of like the ugly stepsister of endometriosis in that instead of the disease being outside the uterus, now you have this glandular growth within the muscle wall. And so for people who have adenomyosis and have an IUD placed, they still have those glands that are in the muscle body, which can still be contractile and irritative. And so for many patients, having that IUD placed leaves them with this feeling of pressure and irritation, especially with the copper IUD, which is designed to cause mild irritation and inflammation. And right, the name of the game is anti-inflammation for endo. So many patients feel much better upon removal of those. I will say that, you know, adenomyosis is probably one of the most missed diagnoses that's very nuanced, that unfortunately really does require an MRI to look at something called the junctional zone, which is that interface between the endometrial cavity and the muscle, to figure out what it is. But you know, I think in the future, we should do another session to go deep into the stuff again, because adenomyosis is really underappreciated, and I think it's much more common than people recognize.
100%, 100%. I totally agree with that. And it's equally as destructive to health and mental health and physical health. Okay, I think we've got one last question here. Is there any tests or are there any tests we should do to monitor endo besides annual visits, any blood tests to check hormones?
So the person who
Oh,
invents the blood test will be a cajillionaire. Um, they will
what did you
do
say? Sorry, I missed that.
the person who invents the blood test for endo will be like a very
Oh,
wealthy individual.
yes.
Um, Unfortunately, there's no blood test to date.
Yeah.
Um, with that said, having a gynecologic examination is probably the best way to figure out the progression of disease if you're having any. The standard of care in this country, in the United States, is not to do a transvaginal ultrasound for an annual checkup. Is to do a bimanual exam, and that bimanual exam, where you're pushing on the exterior of the body and feeling from the interior to see if there's any pain or irritation or nodularity or growths in the trained hands, is actually probably one of the most sensitive tests to be done. With that said, I think you can definitely have a transvaginal ultrasound on an annual basis just to better visualize those ovaries and to see how's it look. Do you see any disease? Do you see any progression? Do you see a cyst that's forming? Because an
Mhm.
unrecognized cyst can actually cause the ovary to twist, which can be a
Mhm.
life-threatening and fertility-threatening surgical emergency. So there is
Really?
some utility in preventing that.
Awesome. Wonderful. Okay. I'm sorry. I keep saying last question, but
This is the last one, I promise. So let's
okay.
do this one.
This is a good one, actually. How can we know how deep the endometriosis has reached? Is that more related, like, to surgical?
Great
Yeah.
question. So everyone says to me, my pain's a 10 out of 10. Does that mean that I have, stage 4 endo?
Yeah.
And the answer is no. Even the smallest lesion, the little powder burn lesion in the pelvis, can
Mm.
cause the most irritation. So you have to have a surgical excision where someone has to go in through your belly button with a telescope, and they have to remove the disease from the actual lining of the body and send it to a lab to understand how deep the endometriosis is. But yeah, it's really the trained surgeon in their hands to figure out the correct answer.
So it does have to be done laparoscopically, right?
Or
To know how
laparotomies
deep it
in
is.
some countries where they don't have access to laparoscopy. That's correct.
Okay. Just to follow up to that previous question about the testing, do you find it's valuable to do like like a serum estradiol or progesterone blood draw? No?
No, unfortunately, many patients chase these. And I can tell you as a reproductive endocrinologist, the utility is so low. Um,
Is that right?
it's really low. It's not worth it. And so, no, you should not be going for serial blood tests.
So like if you get a blood draw though, you can tell if somebody has like elevated estradiol at a certain time of the cycle after if they're ovulating, right?
So, yeah, I mean, I can figure out where someone is in their cycle by looking at three blood tests: their estrogen, their luteinizing hormone, and their progesterone.
Hmm.
With that said, people do these random salivary, like spit levels of estrogens, and they get obsessed with them. And I think it's just unfortunately there's very little utility in them, and
Okay.
they drive you nuts. So skip it.
Hmm. Okay, cool. All right. Well, that was awesome. Thanks so much. We had a lot of really great questions come in
Yeah,
for
we
you.
should definitely
So
do this
that's great.
again. Look,
Sure.
Endo Month is once a year, but I deal with this every day, and so do you.
Yeah.
So I think we'll both work with with our groups to figure out how we can do another one of these because this was awesome. So thank you so much for your time and thank you for sharing your story. I know it's not easy, so thank
Yeah.
you.
Yeah, likewise. Thank you so much. And is your clinic open to people worldwide?
Yeah, we are. So we have 11 clinics across the country and Canada. And we thankfully have seen throughout COVID that we've been able to treat people effectively and efficiently from all over the world, even with the travel restrictions. And so we've been doing lots of telehealth, lots of initial consults by phone, and then we have this thing called a 1 day workup. And during a 1 day workup, what we can do is get people to come in as a couple if they're together, or a single woman if she chooses, and just kind of get all that workup done, right? Like
Cool.
get your blood work, get your ultrasound, get you a diagnosis, and then we follow up the results in a couple weeks when they all come back. Um, so yeah, we're open worldwide, and we are just we feel really humbled and honored to take care of this community because I think that it's a community that's been silent for a little too long, and
Hmm.
it's about time that we gave the attention that endometriosis deserves.
Wonderful. Really appreciate that as an endo warrior from a doctor hearing those words. So that's very comforting. And for anybody who is watching, listening, if you're looking to change fertility doctors, or maybe you're just starting your journey, you may have just met your next fertility doctor. So there you go.
It would be my pleasure. Thank you so much.
Wonderful. Likewise.
And I look forward to working together again in the future. Thank you so
Yeah,
much.
awesome. Likewise. Bye, Dr. Levine. Bye, everyone.
Bye.